So one more time, I apologize, Clay. I just want to inform you that we are on the NEMSIS TAC public training. Today is Thursday, June 21st, 2018. This webinar is intended for state and territory EMS data managers, EMS agency representatives, and members of the general public. Dr. Clay Mann, who is the principal investigator for the NEMSIS Technical Assistance Center, will be sharing information related to the need for revisions to the current NEMSIS standard. And I will now turn the time over to Dr. Mann for this presentation.
Thank you, Monet. It's a pleasure to be with everybody today. Thank you for joining. Lots of folks on the call all the way from Washington State to Florida, so thanks for joining. This idea of versioning NEMSIS is incredibly important to all of us, as NEMSIS has become such an important national standard, and it's used so often that it's incredibly important for us to try to get it right. And as folks probably know, there's kind of additional pressure right now as we've spent the last year really looking at the NEMSIS 3.4 standard, and if there are any version changes that we should consider. There's been lots of work related to that topic, and right now, actually last week and this week, votes are being held with the National Association of State Officials Board of Directors in regards as to what part of the work that's been done this last year, or as a total, will move forward into a revision cycle. So we were told that it might be valuable for us to go through really the process of NEMSIS versioning, what's happened in the last couple of years that's brought us to this point. Some folks may have heard a fair amount of this presentation. Much of this will be new, but hopefully everyone will walk away with a better understanding of the decisions that will be made this Friday, actually tomorrow, and what we've done leading up to this point that's brought us to the vote that will happen tomorrow. Well, so let's go ahead and talk about what we want to cover today. We're going to go back a little bit in history and talk about what were some of the really glaring problems with NEMSIS version 2 and why we wanted to make a major change into a new version, version 3, and whether or not we've been able to fix those issues with 3.3.4 and 3.4.0, the two really NEMSIS standards that have been used in the field. What are the potential benefits of moving to a new version of version 3.5? Those potential benefits relate to the suggested revisions that have been reviewed over this last year and have found to have merit. Let's review some of those. And then give you an idea of what is the current versioning timeline that has been decided over the last few weeks. So this is very timely information. So this is kind of some old school information. Many folks are aware of this. These were the major reasons why a movement to version 3 was so sought for. Many of the elements included in version 2 were considered incomplete. Primary symptoms that could be recorded by a provider were quite truncated. There were really only 12 choices for an incident location, woefully too short of a list. Also, there was an inability for a provider to record why they didn't do something, so what we call a pertinent negative. So if you were dealing with a patient with chest pain and decided not to give aspirin as per protocol because of an allergy, for example, there was no way for you to be able to indicate why you did not perform that action. Version 2 dataset was built for the major purpose of having a national registry, so it was kind of epidemiological in nature. It was for counting things, and the federal government loves to be able to count things. We needed to make it a little more personable and usable at the agency level. Also, the dataset was not timely, and like most national and state datasets, the data that was available was quite dated, and EMS is a different beast. We would love to have a near real-time data set that allows us to look at surveillance issues. Also, the data set was homegrown. The XML structure underlying version 2 was built by Jorge Rojas here in our offices, and we weren't recognized as a national standard. So it was important for us to make major modifications that allowed us to be represented as a national sample, and therefore make funding available to us through NIH or through the federal government, through Medicare and Medicaid as a represented national standard. So those were important issues. I'm going to ask anybody too, if your phone isn't on mute, if you'd go ahead and mute it. We're getting a little bit of background. Please feel free to ask questions. Just unmute and ask your question, and we'd love to respond to it. All right, so those really were the reasons for moving to a version 3. We needed to improve data quality. We wanted to enhance a performance assessment, allow for more kind of assessment of our providers and protocol adherence. We needed to make data be more timely. And so could we really develop a system via web services where data could be fairly real time? And then, of course, we wanted to synchronize the NEMSIS standard with other clinical national standards, and so that we could become what's called ANSI approved and become an American approved standard. Well, let's take a hard look. We've had NEMSIS 334 and 340 on the ground now for a number of years for many states. There are 33 states and territories that are using version 3 and sending data to the national data sets. So we've got millions and millions of records now. We can take a look and see whether or not we fixed these problems. And so let's look at the 4 items that we tried to fix. So improving data quality, yeah, there's been great improvements in the data quality at the state, local, and at the national level due to business rules that we've outlined. So as a record's completed, there are business rules that ensure that some fat fingering or something hasn't happened, so that there's an opportunity to correct the data if there's a mistake made at the field level. We've added pertinent negatives. We talked about it. Here's a slide kind of associated with e-medications or giving a patient medications. You can see there's a number of pertinent negatives now that are allowed, including medication allergy, medication already taken, things like that. Are there cons to the approach we took? Yeah, we built suggested lists, and so many of the elements that we talked about in version 2 that had really a condensed set of values now have hundreds of values because we have turned it over to a clinical standard like ICD-10-CM, and now there are hundreds of values, maybe too many, and so we'll talk about that in just a minute. Okay, it looks like there perhaps are some things, Monet, in the chat you might want to kind of look at if you could. All right, let's move on here. So here's an example where incident type location under version 2 had 12 choices. Now there are hundreds of choices in ICD-10-CM, and we tried to handle that problem by developing suggested lists with a number of expert panels, and then we provided kind of these shortened lists, clearly not hundreds, but still very long lists, into kind of a tiered system to kind of guide the software development to ensure that we're not trying to show 40 choices or 50 choices at once. So we built this kind of a hierarchical system where there may be a first tier button that might say, for example, agricultural site, and if you clicked on that, it would open up a second tier of buttons, so you could kind of increase the specificity of your first choice. So it was clear working through these experts that 12 choices for incident location was way too few, but they still wanted lots of detail in regard to where the incident or the patient was, and so the lists are still quite long. How about enhancing our ability to look at performance? We've version 3 added a number of elements. Most of them are listed here. These have been incredibly valuable in our ability to kind of look at the performance of providers and the value of protocols. Maybe some of the cons associated with these additions is that these are all national elements, which means they're mandatory to be completed on every single patient care report. So we literally added, a handful of elements that need to be completed every time a patient care report is initiated. How about data transfer? That has been an incredible improvement, right? So instead of really only having data available at a national level once a year, now our record submission is automatic through web services, and when things are working very well, a provider can close a record in someone's living room, and then that record is passed through the local product into a state registry and then into the national registry really in about 7 minutes. Now, each state can look and see how quickly records are coming into their state repository, and it's usually longer than 7 minutes just because of the traffic. But we're really down to looking at a national registry that is up to date within a few hours, which is just incredible. One of the cons associated with this is that it's really not related to how fast records travel, but each of the states have really presented a dilemma where they'd like to use the demographic set of NEMSIS to be able to track, personnel or resources within an agency over time, and there really isn't a way to do that in the current standard. All right, the last item, trying to make NEMSIS not be so homegrown and be more of a national standard, so we were able to take the version 3 standard through what's called HL7. It's a Standards Development Organization, Health Level 7. And we did gain ANSI approval, so we are a national standard. Version 3 is a national standard. We were required to utilize these national clinical content standards like ICD-10-CM, SNOMED, LOINC, RxNorm, but they're quite clunky when it comes to pre-hospital care, and so we still have some work to do to make sure that they work well. Also, in the years that version 3 has been available, we really haven't seen the data exchange growing as much as we'd hoped, right? So there's an e-outcome section in NEMSIS where we hope to get patient outcomes back into the EMS patient care report, but really only about 20% of agencies are seeing that benefit. So we still have work to do there as well. So with these, knowing that these cons were present, we conducted a survey 4 years ago where we asked a random sample of state representatives and also providers that work within states what was or was not working under the current version 3. And really the consensus came down to 5 items. It was felt that there were too many elements that they had to collect on every single patient care report. The use of these national clinical content coding systems was still too complicated. It was still too clunky. It wasn't working well. And there were elements in version 3 that just remained confusing. E-disposition 12 was a perfect example where there's really 3 types of disposition included in one element: a patient disposition, a call disposition, and a transport disposition. We're still getting a little bit of feedback, so if someone isn't muted, please mute if you could. Also, state users, as I mentioned, they were looking for a way to be able to track their personnel and resources used within agencies, and agencies wanted to do that as well. So that would be a great value. And then how can we improve our ability to share and exchange data? Lots of data, I think, is being exchanged with hospitals, but we're still having difficulty getting hospitals sharing data back with EMS. And so how can we improve really both of those exchanges? Well, so last summer, almost a year ago now, we organized summer work groups who really tried to tackle each of these questions, right? So each of these problems we've talked about. Are there national elements that need to be demoted, right? Do we need to collect all of those elements on every PCR? These suggested lists, can we narrow those down? Can we make them defined lists, and so every product is using the same lists? Do we need to split some elements like e-disposition 12? Can we introduce a universally unique ID that would allow us to be able to track resubmissions, track update to a personnel file or to a resource? And so if a personnel takes a new certification, it can be added because that person has this unique identifier that tracks with that patient or with that provider over time? And then how can we modify the outcome section to make data move more efficiently? Well, these summer work groups did some incredible work, and I know Jesse was on one of those. Jesse Haas is with us today. He was on one of those groups, and when I look at the list, there was a number of people who were actually in those working on the summer work groups. So, thank you very much. We were careful, I think, once we had the recommendations back from the work groups to ensure that any revisions that were suggested or any ideas that would kind of bubble up as a result of this great work, we needed to make sure we were looking at the costs and benefits associated with making any change to the standard. Making changes to the standard can be incredibly costly in regards to time, resources. We list the costs here. Those costs are borne by agencies and they're borne by states. Anytime there's a change, there's some additional training necessary. New training materials need to be built. There's just new costs, and in some cases even legislative or agency overall changes that need to be made that can be quite costly and time intensive. We want to balance those with the benefits to our providers, right? So Doug Fuller, data manager at Nebraska, is always reminding us this is all about the patient, and so the benefits are we increasing the clarity by making this change? Are we increasing the clarity of the patient care report so that we can reduce the time necessary to complete that record, and it can be more accurate, and it can flow better in regards to how a common incident occurs? Those are the type of benefits that we could gain with some changes. So those were always kind of front and center. So let's talk about the big ideas that were covered in the summer work groups, what happened last summer. There were two summer work groups that were dealing with topics that really sit under the hood, right? So if you think about a cost-benefit analysis, adding a universal unique ID or enhancing the patient outcome section, neither of these topics really touch the provider. They don't have to complete any new data related to either of these two topics. They both kind of sit under the hood. Patient outcomes is data that flows back into the record, so our providers don't have to provide it. So the cost in regards to training or other things is quite low, and there's great benefits. So these were kind of a slam dunk in that there were great benefits with really little cost associated with making these changes. What about the idea of there just being too many national elements, too many mandatory elements? So the summer work group I was really quite aggressive and said, hey, let's demote 15 elements that had to be completed on every patient care report. Let's demote those so that they don't have to be collected on every report. There are 3 that we probably should make national elements, and those 3 are listed here. So overall, there's really a reduction in 12 elements that would need to be completed on a patient care report. So again, the costs of making these changes, clearly there'll be costs because there'll be some new education, some new training, but the benefit could be great, right? If on every single record we receive millions per year, 12 less elements have to be collected. That's a time saving and hopefully allows our providers to concentrate more on patient care. Okay, what about these suggested lists, these 16 elements that require now the use of these national clinical content standards and coding? Great work was done here by the work group where they said that for 13 of those elements that utilize those national coding schemes, let's make those defined lists instead of suggested lists. There are 3 that we probably just can't make a defined list because the universe of where you could have had any kind of a past surgery or current medications could be anything that would be included in RX norms. So these really couldn't be made defined lists. We really ended up not moving this idea forward as much as we'd like to because when we actually talked to providers of software, they felt like they had made some great strides in the intelligence of their software to work through large lists by having a hierarchy or using a logical lookup. And so we wanted it to take a harder look as to whether or not we need to upset the apple cart here, or whether it just took time to get it working right. So again, here there are costs associated with making these updates if these become defined lists. But again, the benefits, if we can allow our providers to move through these codes more efficiently, that could be incredibly valuable. All right, and then the other kind of big idea that was looked at was splitting e-disposition 12. So now there being 3 elements instead of just the one, so that we could clearly look at patient disposition, incident disposition, and transport disposition. One of the big issues associated with e-disposition 12 now is if one provider agency hands off care to another agency, there's just no way to provide that in the data set at all. And so you can see the orange pieces that were added here that really allows, with these 3 elements, to clearly define if you hand off care of a patient. The costs associated with making this change are great because lots of business rules are tied to e-disposition 12. There's lots of interconnectedness associated with e-disposition 12, so there would be lots of costs associated with it. There's also great benefit, right? It would be much clearer for our providers to actually document a call, and some are undocumentable now. So there's clearly benefits, but there will be costs, higher costs here. There were also 125 other kind of ancillary revision requests that were made. We had an open call for people to provide suggestions. Those have been reviewed over this last year at least 3 times by expert panels, and really 61 of those 125 have been kind of rejected, that they wouldn't be included in a next potential revision. 64 of those revisions were considered to have merit. They were polished up somewhat, and if we were to move forward with another revision, folks felt like these 64 could be included and would increase our ability to provide proper patient care documentation. Here I just provide a snapshot of a PowerPoint presentation that's available to you on the website that kind of shows you an idea of a request for a revision. And then you can see that there are 2 horizontal bar charts. These combine 3 reviews of this element. The bar charts on the left combine 2 reviews. But during those reviews, everybody had an opportunity to independently indicate whether they thought this was would be a revision with merit or one that should not go forward. And the green bars indicate that folks felt like this had merit. So this idea was clearly related to the idea that NEMSIS and CARES, which is popular across the country, they need to do a better job of harmonization. And we've been working hard on that, so this has been a great recommendation. Overall, if you look at this 125 suggested revisions, and then you just look at the 64 that are moving forward, if you apply those to a cost-benefit analysis, there's really 64 of these suggested revisions that are truly kind of a benefit as we've described. They increase clarity, they reduce time in data collection, or they increase the flow of the record. There are 19 suggestions that really aren't related to a cost-benefit analysis. They're really just a definition clarification or a misspelling or a technical fix that needs to be made to the standard. This is incredibly important because why NEMSIS works is because we at the NEMSIS TAC test every software product for compliance to an exact XML structure. So we are sure that across the entire country, when they test for compliance, everybody is using the exact same programming, structure, definitions, values for elements. All of them are exactly the same. So if there's a misspelling, that misspelling remains present in every single product because they have to test for 100% compliance. We don't allow people to vary from the standard. So that becomes really important that we have an opportunity once in a while to dig in and kind of fix these technical issues. But there are 11 suggested revisions that do have some cost to states and providers. These are mostly related to either adding new elements, and so we talked about e-disposition 12, where it was one element, now it'll be several elements, or removing an element. Clearly, there are costs in regards to training and time and resources related to those. So here's just another example of what some of these revisions were to give you a flavor for these. So here's a suggested revision to e-medications 10, the role type of person that was administering the medication. We, in version 3.4, have this patient/lay person as one choice. Clearly with the opioid issue, it has become important that we separate those, right, so that we can actually determine whether or not a patient or a lay person has offered a medication to a patient, particularly related to Narcan. This would be an important change to make. As an example, some changes, as I mentioned, are really easy. So here's a misspelling in our XML structure in the XSDs where we actually misspelled AVPU. That needs to be corrected. That remains a spelling error across all software. And then there were much harder suggestions. Like here was a suggested revision to add a number of additional values to depersonnel, including, an EMS personnel's hair color, eye color. You can go through the list. This one was declined. It would have been a big change for NEMSIS. So lots of time and effort has gone into kind of understanding that our role here is not to just make changes, but it's to make changes that ensure we're improving the experience of our providers and so that they can improve their ability to provide good quality patient care. All right, so that's a real quick rush through kind of the history associated with versioning all the way back to version 2, what brings us to the current point in version 3. Let's talk a little bit about the versioning timeline that was changed just a couple of weeks ago. So here is the proposed idea in regards to moving forward. So we have spent this last year refining these suggested revisions. We had hoped in May to have all of those requests finalized and a vote held by the NEMSIS Council. As I mentioned, there's a vote happening this Friday, so we're really not too far off of this timeline. And if you look through this timeline, you'll see on the top here we talk about the 3.5 version, so you can see that we wouldn't have a candidate release out for vendors to kind of take a look at until May of 2019, so in a year from now, a final release in September, and really wouldn't be expecting the software companies to have version 3.5 options available until late in 2020 into 2021. Then on the bottom of this timeline, you can see when, based on this 3.5 plan, when would we be closing the current standard? So you'd see that we would be closing 3.3.4 in 2019 and closing 3.4.0 in 2023. Quite an extended time period there. Latest revisions that just happened as of this month, you can see we've added 6 months to this section to kind of allow vendors kind of more time to work through the processes of creating a 3.5 product. And then we've extended this section by a year so that vendors have more time to ensure that their products are robust and that states have a longer period of time before they needed to move to 3.5, and we've moved out these closure dates on the current versions. So highlights of that refined timeline, we would be expecting software companies to have products out in 2021. Version 3.3.4 would close in September of 2019. That will mean that it has been opened and used in the field for 6 years. Version 3.4.0 would close in January of 2023, meaning that it would have been opened and used by providers for 8 years. Now, of course, all states haven't moved to version 3, and so really only early adopting states would see these long time periods on these past standards. So let's take just a moment here. I have just about 5 more minutes left and would love to entertain questions. Let's go to the website. If we could, I wanted to just go through a couple of quick items here that I think might be helpful if you want to dig in deeper into what's happening with this idea of a 3.5 revision. So if you go to the NEMSIS website, just nemsis.org, and you go to the bottom here, you'll find a section where we have all of the materials associated with the 3.5 revision requests. And if you open it, you'll see here that there's some introductory videos you can watch that help familiarize you with the work that has been done. And then the big ideas we've talked about are listed here with lots of information related to, for example, what would it look like if we added a UUID, a Universal Unique Identifier? What elements do we actually plan to promote or demote as national? You can find those listed here just by clicking on, for example, the recommendations. You'll be able to open those and see what elements are suggested to being demoted, removed as a national element, those that were reviewed but there decided to be no change, and then you can see for the bright green those that are considered for promotion, and you can go in and read the recommendations why they'd like to add these as national elements and why the others are being demoted. So this could be very helpful. Also, lots of information regarding splitting e-disposition 12. This has clearly been the most confrontational, controversial suggested revision. So there's lots of detail here that could be incredibly valuable to understanding that idea. Then here you'll find each of those 125 potential revisions here in 3 batches. You can open up these PowerPoint presentations and you can look at each of the suggested revision. You can look at the voting associated with each of those. All of that information is there. In a more kind of truncated form, we also have here an Excel spreadsheet that is really helpful to kind of review all of the 125 revisions that are in these 3 batches. So you can open up this Excel spreadsheet and then you're able to look at everything that was reviewed. And was it considered not in scope, or was it considered to move forward for consideration? All of them are listed here. What the revisions are is under this summary. And then there's really paragraphs of information. If you opened up each of these cells, there's paragraphs of information, written information regarding discussions on each of these topics. And it's all searchable, right? So if I wanted to just look at those items that are considered that they should move forward, I can do that. If I want to only look at those, let's say, that will improve a provider experience, will have no change in a provider experience. We talked about these 3 categories, or those would have some impact. You can go through and see, I just want to look at those that would have some impact. Then you can choose those. Here you can see the revision type, that these are the addition or removal of elements or important values. And here is the data set that they're involved in. Here's the element that's involved. Here's what's being requested as the change. And then, of course, you can look at all the discussion associated with just specifically those if you wished. The value of this is say you find one of these revisions that you really want to kind of drill down on. So here's one dealing with e-exam 20. Well, if you look here under column A, it indicates which PowerPoint ID, which suggestion ID is associated with that that idea, and which of the 3 PowerPoint batch numbers associated with that. So this e-exam 20 is associated with the PowerPoints in batch 1, and it's ID 1. So if you look there, you find that information, you're able to go back to the website, and I'll open up batch 1, and let's just go down to ID 1, and yeah, that has to do with e-exam 20, adding a value of status seizure to e-exam 20 to make it so that it would allow the compass measures to work correctly. So you're always able to go back and take kind of a deep dive into what were the decisions associated with any particular element. And then the timeline, as I discussed, can be found here as well. So you can actually look at the timeline, and we also have a duration timeline, so you can look at how long we'll spend in each major processes of moving to the new standard. All right, so then the only other thing I'd like to show you just real quickly, if we go back to the web page, there will be much work done over this summer, and we plan to meet together as stakeholders in our annual meeting that will be held August 20th and 21st of this year. All information regarding that meeting can be found here. This meeting is richly attended by vendors and by state data managers, and is a great opportunity for us all to be face-to-face as we walk through the final kind of revisions associated with what might happen under 3.5, depending on the decision this Friday. But lots of good information here if you'd like to consider attending this meeting. All right, so let's go back to the PowerPoint slides. All right, and I'm gonna pause there. We have 20 minutes left, so I would love to have the opportunity to talk about any questions or any thoughts you might have about what's happened over this last year in regards to preparation for a potential revision to NEMSIS. So I'll open up the floor, please.
I am currently in the process of unmuting everyone, so if you do have a question, you can either enter in the chat or ask it directly. I'm almost complete with the unmuting process. So everyone is unmuted.
Clay, this is Jeff at the MSPIC. I was just wondering, you'd mentioned there's a vote that's happening tomorrow. Can you explain what that's about?
Yeah, Jeff, happy to do that. So a little bit of background. Earlier in May, we had the annual National Association of State EMS Officials meeting in Rhode Island. The data managers met together, and they reviewed one last time the package associated with the elements, the revisions that were considered. We're calling them agile, right? So these are the revisions that we have reviewed and polished. Agile just means that we think we have enough information to go ahead and make this change efficiently to the standard. So all of the agile revisions, the 65, were voted on, and they decided as a package that they would approve all of them and that they needed to move forward to the NEMSIS board for final vote. So that happened, and the motion was accepted by the board of directors. They met last week for a final vote on the DMC motion, the Data Managers Council motion, but for a variety of reasons, they considered that vote to not be valid. A number of people had dropped off the call without folks knowing. The call went over, so they're holding an off-schedule call again tomorrow at 11 a.m. Eastern Time, and requesting that the board get on the call so that they can have a final vote on what moves forward, whether it's everything that was marked as agile or if it will be a subset, or whether there'll be no changes for the foreseeable future. I doubt that will be the vote, but that's could be on the table. Does that answer your question, Jeff?
Yes, thank you, Clay.
Yeah, you're welcome. Any other questions regarding any of the products that are on the website or any of the history related to what brings us to this current point? Okay. All right, Monet, I'll turn it back over to you. Thank you very much for this opportunity to present this information. Hopefully it was understandable and everyone has kind of a clear idea of where we stand in regards to NEMSIS versioning. Lots of important decisions will be made this summer as we move forward, and we will try to keep everybody up to date in regards to those decisions on our bi-monthly V3 implementation calls. So please feel free to join those calls as well. Monet, I'll turn the time back over to you.
Thank you all for participating. I do realize that NEMSIS is new to some who may be on the call, and you may be a little shy to ask questions on the phone, but please feel free to click on the staff contact page, and our telephone numbers as well as email information is there, and you can submit a question directly to us via email. I am also looking for topics that we may want to have additional trainings on. So if you feel like there's something we have not yet covered, please send me an email indicating what the topic issue is, and we can try and schedule a future training for that. And I also may be reaching out to some of you who were on the call to solicit ideas for future trainings. Thank you so much for attending this call, and have a blessed rest of your day.